Good morning from New York or anywhere you may be around the world watching this live webcast of structural cases. Today we have a valve case, and before we go to the cath lab, I want to welcome you to the site to register for the CCC Symposium, Complex Cardiac, Coronary, Valvular and Vascular Cases, June 17 to 19. At the AXA Equitable Center near Times Square here in New York City, with a lot of live cases from the Mount Sinai cath labs and the chance to meet and greet in person all the operators who will be on site and go over with you the tips and tricks of the various cases. Again, the registration is open at the cccsymposium.org website. During this webcast, you are free to send me any question. I will filter it to the operators or discuss it during the presentation of the case at info@structuralheartlivecases.org. Again, the email is info@structuralheartlivecases.org. And without any further delay, I want to connect with the cardiac cath lab, Dr. Samin Sharma, Dr. Kinney, and co-workers, Dr. Stelzer as well.
Yes. And Kovacic and fellows.
Well, I don't see
Dr.
Kovacic yet.
Fellows will come too, Suresh. Yeah. But anyway, welcome. This is our structural heart. Yes, exactly.
It's Dr. Kovacic and Rick in the back, and I'm sure Dr. Parthos and Gupta on the other side with the echo, and our fellows and our nurses, Liz and CoreValve team as well.
And our anesthesia. The team, you know, they're very influential or helpful to get the patient started. And many times when we feel that patients, like this case, we felt it will be under conscious sedation, but if they feel for some reason patient will not tolerate or patient unstable, make the spot to make it, you know, change the route or approach basically. So this patient actually initially we planned to be as conscious sedation, but then decision was made to intubate. And many times we do it for clinical reasons, so the patient can very well be, you know, procedure goes through uneventful, and this patient could not lie down flat, and that was very moving and very unstable from that point of view, so he's intubated. Okay, with that note, I think we can start our presentation because we are ready. And sorry for a little delay. Clearly, and this is, we'll go through the slides quickly first. Next. This is our disclosures. Next. Now, this is a 77-year-old male who has progressive exertional dyspnea and fatigue for last 2 to 3 weeks more, but has been having this for last few years, but more for last few weeks. Was admitted to outside hospital with exacerbation found to have clearly a critical aortic stenosis, and he is also an atrial fibrillation, is on dabigatran. Echo, which we will show, showed severe AS with a low ejection fraction of 20% with pulmonary hypertension and RV dilatation. Coronaries are non-obstructive. Next. So basically, the CT will go again with in terms of the vessel size, both right and left. As we know that for 18 millimeter, any valve, so that we need about 6 millimeter vessel size, so that they both are just about 6 millimeter plus. Left is better than right, and I know Jason has prepared the left side, and the mean aortic annulus is 2.5 with STS risk, mortality, and Euro scores are shown here. The patient was felt to be high surgical risk because of ischemic cardiomyopathy, and I'm sorry, this the last line is not correct, but this is just for ischemic cardiomyopathy. Next. And we plan from the left side. Maybe now Partho can take us for the echo in this particular case, although we can take a live echo rather than what we have already with a very high gradient, and this patient did not have any balloon aortic valvuloplasty before.
Yeah, I don't know if Dr. Stelzer is mic'd. Maybe he could make a comment from a surgeon point of view in this case after we see the echo. Go ahead, Partho. We see the echo very nicely in the camera.
Yes, so what you see right now is the severe LV dysfunction, ejection fraction 20 to 25%. And then you have the severe aortic stenosis. This is the transgastric view, which is showing also mild aortic regurgitation. confirmation of the gradients. You can see here the mean gradients of close to 40 with a peak velocity of 4.1. And then we also discovered, since the patient is on atrial fibrillation, there is an organized left atrial clot, appendage clot. So that information was relayed to the team because that will impact the anticoagulation management after the procedure. And there is a presence of mild to moderate mitral regurgitation. And finally, when we come to the aortic valve complex, this is the long axis view. You can see here that there is severe aortic stenosis, a lot of turbulence, and also there is mild to moderate aortic regurgitation. The short axis view was then subsequently obtained in three-dimensional view. This is the live three-dimensional views which multiple slices taken. And then we go ahead with the turnaround principle, calculate the annulus. Now you can see here the annulus, which is very elliptical, extremely elliptical annulus with the circumference of 8 centimeters. And Jason will talk about this, about the CT. But the measurements that we obtained here was the long diameter of 2.8, the short diameter of 2.2, and the circumference perimeter of 8 centimeters. And what is also interesting to note is the amount of calcification. It's an extremely calcified valve, but there's an asymmetric calcification. You can see here this is the non-coronary cusp, which is really has much more calcific spot there. This commissure is more heavily calcified. So there is an asymmetry in the calcification, and this is important because this can predict the development of paravalvular regurgitation and need for subsequent dilatation. And more importantly, you can see here there's a calcific spicule which stands out from the commissural end, and this spicule is important to keep into consideration. And again, the confirmation that the LV outflow area and the geometry of the annulus is pretty elliptical. So these are the highlights of the echocardiographic evaluation.
Just a clarification, Partho, in the 3D you show us now, for the viewers need to understand that you have it at the annulus level. Okay, you just changed it. Before
right,
you had it at the annulus level,
yes.
So we could see the elliptical, but the fact that it looks rather open is not really a valve level. It's just at the bottom of the cusps.
Correct.
Just to appreciate the annulus, which is a
Correct.
very nice picture. But at the same time, I don't want the viewers to be misled that somehow the valve is opening without stenosis.
Right, so this is, you can see here the plane has been brought at the annulus. So this is the hinge point, right. And you carefully rotate across all the 3 leaflets. This is a tri-leaflet valve, and make sure your plane is at the annulus level, and then take the measurements there.
Okay, we go to the next point which George asked earlier. That in this day and age of this kind of patient, who although have a lower surgical STS mortality, about 4%, that what is the right approach, knowing that the TAVR are being done in these, actually he may not, based on the criteria, he although becomes intermediate risk. But from surgical point of view, with the additive, sometimes STS mortality risk may be higher. So, Paul, what is your feeling in these type of patients now? That should we do a balloon valvuloplasty, see what the EF improves, or just go directly with the surgery or the TAVR?
Well, I think we've shown that we can be extremely effective with TAVR in these patients. And you have a patient who has some other factors like the lung cancer that may limit his life expectancy, and you don't want to spend 3 months getting over a big open heart operation if your life expectancy may be limited. Frailty is also something that's very difficult for us to quantitate with numbers. So I think that it's important to consider that, and the performance status, how much can this patient walk. And we've got things that we can take into consideration on the STS score with the COPD and so forth, and even ejection fraction comes into play. But I think that more and more we're going to be referring these patients for TAVR as opposed to open surgical treatment.
Okay. Okay, we can. I think that makes perfect sense. And this is what has happened is that clearly the TAVR has added some number to numbers to the overall aortic valve revascularization or replacement, not necessarily decreasing the surgical volume for the time being. Although I would say once the intermediate risk trial data comes out from partner 2A or CERTAVI, the things may affect some of the surgical volume, and that largely, but still there will be a more patients because those. What has happened, TAVR actually really has opened up the field where many practitioners, the patients, community felt nothing should be done. Now all of a sudden those patients are being referred for this very exciting I would say, remarkable procedure. So we continue with the access point of view. We get the slides back.
Show the slides, please. Good. So as always, we start with the annular assessment on this patient, and pretty much exactly as Parthos and Gupta just showed us with the echo, we got a very elliptical valve with in 2D diameters of about 28 to 29 millimeters by 22, with a mean of 25, giving us a perimeter of around 79 to 80 millimeters, an area of 4.9. So this actually, it's very concordant with exactly what we saw on the echo. And in fact, Parthos and Gupta was just the senior author on a paper we had published in JACC Imaging, showing exactly that with meticulous echo you can have very good concordance with the CT measurements. Next slide. So some other very relevant measurements we need to take before we plan the procedure. As we plan the procedure, our sinuses of Valsalva, about 36 to 37 millimeters in diameter, and the sinotubular junction height was around 23, 24 millimeters on average. And we'll come back to these measurements in a moment. Next slide. And here you see the ascending aortic diameter was about 31 millimeters, and the annular plane was about 48 degrees, which is very standard, and it's not a particularly horizontal aorta, which brings its own challenges. Next slide, please. And here you can see the coronary ostia height, so the RCA is about 14 millimeters, and the left main is around 12 to 13 millimeters. So these are within comfortable margins. Less than about 12 millimeters, we get worried for the coronary ostia occlusion. Next slide. And so here you can see the sizing grid for Medtronic CoreValve. This patient falls within the 29 millimeter valve sizing by all measurements. You can see our patient's measurements across the bottom there, and by all accounts, by all the relevant measurements, this patient is appropriate for a 29 millimeter valve, and we confirmed that with transesophageal echo just now that they got the same measurement.
Was there a very good correlation in this case? I think this is because he had a very good visualization and a good angle plane in the TE. Some cases we see some discrepancies because sometimes the imaging is not perfect, but in a case like this one today, we see that actually the imaging was great with both.
Yeah, it's a very good point, George, and I think I'm very demanding on the quality of the CT that we take, and I do send people back to be rescanned if I'm not happy that we're getting accurate measurements. And I think the techniques for both are evolving, so that we're in the early days there used to be discrepancies, but as we just published in JACC Imaging, we get very good concordance here between the transesophageal echo and the CT in our hands. Next slide. So to the imaging. This is a 3D movie. If you can click again, it should play, hopefully. This is showing you in 3D the access vessels. No, it didn't play. Just go back one. You can see the access vessels are reasonably straight. There's some spotty calcification up in the aorta, but nothing obstructive, and the vessels are around 6 to 7 millimeters all the way up. Next slide, please. So to the access point, and what you can see here is the common femorals left and right. You can see there is some significant calcific disease in these common femorals. And we deliberately go to avoid these trouble spots. So if you go through to the fluoro on the next image, back to the live fluoro, and I'll just show you. So if you can come off for a second, okay? Yeah. So what's important in these cases is we actually respect these calcific points. And what you can see here is where we're actually going very high on the access point. This is higher than we'd normally recommend to go for if you have the choice, but in this patient it was either go this high or engage all of that calcium and run into risk of having trouble with the access. So this is still below the inguinal ligament. I do routinely stick here if necessary, but that point on the CT was free of calcification. We safely got the perclosers down without any trouble. We just checked our right access point. Then we deployed the two perclosed sutures, went up and got our annular root shot, and you can see here we're just aligning the three cuffs of the aortic valve in the appropriate plane, and then we delivered the sheath. Here you can see we're driving in an 18 French solopath sheath. This is after the two pre-closers are down. This sheath goes in at about 12 French diameter. Then we inflate the sheath, which you can see us doing here. This sheath goes to 20 atmospheres for 1 minute, and then it's set and ready to go at an 18 French diameter. So that's all for the access, and I'll hand it over to Dr. Kinney to take us through the procedure.
And the last slide, if you just sum up, basically the high-risk case. Now, maybe we can ask our anesthesia director, Dr. Levin, in terms of decision about patients making a conscious sedation versus, I know he may not have mic, but next time maybe we'll think about it. So this case we felt that could be done conscious, but your decision was, let's intubate.
Well, when I he stated that he had extreme difficulty lying flat, and that he also he had issues with his
We
knees.
don't have a very good audio capture.
But I will translate it. The
Very
same
good.
thing, that patient could not lie flat.
And when we assisted him onto the table, it proved to be true. We had to give him 3 or 4 pillows just for him to be able to lie comfortably while we were placing the arterial line. And speaking to him and assessing the situation, I felt that it would be safer for him to be intubated under general anesthesia to avoid any risk of movement or discomfort for the patient. Also, the significant pulmonary hypertension and the poor right ventricular function. When a patient is lying flat, that can be exacerbated significantly, and then if he gets a bit hypoxic from the sedation, constant sedation, if he gets hypoxic and hypercarbate, that can also exacerbate the pulmonary hypertension and cause right heart failure. So from all aspects, both his clinical presentation and the physiology, I believed it was safer to have him under general anesthesia.
Great. Those are great points, and if things go well, you'll extubate the patient on the table here. Okay. All right. Now here, we can go back to our angio now. Dr. Keeney is trying to cross the valve as we started very heavily calcified. You can see there.
And you have an AL1 catheter?
Well, yeah, I started with the AR2 first, but apparently it was moving quite a bit, although it's not a very dilated route. Our is that if you are route dilated, then maybe go with the AL, but in this particular case, AR was not even coming close. Maybe we can decrease the rate a little bit because pulse rate is still about 105 and 10. Then now with the AL, with the stiff shaft 038, our glide wire, Terumo stiff shaft. Okay, say what do you need to say now?
You want to go a little bit more LAO the camera to allow a little bit opening? Yes. Yeah, I went from 17 degrees to about 25 degrees.
So I think we can see the wire comes into the outflow. You'll see the wire movement.
Yeah, it's in between the two positions. He oscillates, finds one cusp and finds another cusp, and then naturally the valve opening has to be in between. A little tricky because it moves from the jet of the valve in this case. But
while we are doing it, this patient is on heparin, so the ACT is around. Yes, say about try to keep it 300. And George, you can update us, knowing that we published the data on the Bravo trial that heparin versus Angiomax, bivaludin was superior to heparin. And what is happening with the bivaludin and TAVR?
Yeah, this is great. Actually, I just can update just this morning about that. Following a preliminary analysis and initial data, I should say, not preliminary, in many patients, over 400 patients on Mount Sinai with a balloon valvuloplasty performed with bivalirudin. A randomized trial has been undertaken in Europe and in Canada, where the valves were in much higher level, approved valves were used, and already we have over 700 patients, actually as of today, 736 randomized patients into bivalirudin versus heparin. We hope to complete the study within a month.
Of course.
This study, although planned to come to 6 US sites, it was never able to come here because it enrolled very fast in Europe and essentially not worth to come here by the time the regulation in the United States could be undertaken. In the US sites could be starting maybe January or February of this year, but as you see, we have already been completing the study by May this year. So this made no logistical sense to initiate the study in the U.S. So we will have final data of this study at the TCT and AHA conferences of this year in the fall, as we anticipate all the randomized 800 patients to be enrolled by May or June of this year already. And obviously the fact that the DSMB has been supervising and assessing the safety of the study thus far, we can attest that no safety parts have been violated in a major way. We will wait for randomized study results later this year.
Very good.
And from a final point of view, Dr. Sharma mentioned perhaps that it was done very fast, that the patient has been loaded with Plavix and aspirin from day before in such a percutaneous case. If we have an alternative access such as transthoracic or transapical or transaortic, then we withhold the clopidogrel loading dose from night before. But in a case like this one, we load the night before with clopidogrel and aspirin.
Okay, very good. Now we have crossed, Anu.
Yeah,
You take over.
I mean, if you see the aortogram, you actually can see the valve opening. Based on the aortograms, we know that the root not dilated. That's why we went with AR2. And the way we would like to do is go with the AR2, face it where the opening is, and just use a straight Terumo wire. And you usually should not take long time to just cross the valve. But maybe because of AFib, and usually if also what happens is if you have a narrow opening and you have a strong jet coming out, this floppy tip, straight tipped wire keeps getting deflected. But we had to go with the AL1. It took us longer than we usually would, and we have been able to get the catheter across the valve, and he has a gradient between 40-45. You can show the gradient?
Exactly what we felt.
Yeah.
Now we disconnect. Yeah. This is exactly same. Echo, in this case actually, the echo, CT, hemodynamics all are consistent.
And also now very important is once we have the wire in place, echo, Partho,
Yes,
usually will tell us if the
wire is,
placement of the wire is okay.
Yeah, the wire looks, it's slightly on the lateral wall.
Okay. In that situation, we go with the pigtail and reorient the wire.
You need to
Usual teaching would be that you go with the regular wire and go with the pigtail to the LV, and then you exchange to the stiff shaft wire.
Yeah, but how is the things now? Still we need
It's
to go with
going
the
on the
pigtail.
lateral
Yes, I
side?
think it is positioned asymmetrically on the lateral wall near the papillary muscle,
Okay.
so
Okay.
it's not in the free apex.
Okay, so then we are going to go with the
Pigtail.
pigtail to adjust the wire in a better position. I can tell you in the past we used to pay less importance to the wire, but now it's a key. To me, it's for your successful TAVR and avoid those perforations, the wire is the key.
Yeah.
Now we are in the apex. Good, right?
Yes.
Yeah, yeah, not, clearly when you go to the apex and irritate, there will be some transient VT, but as long as we are under control.
And we have selected 22 Z-med balloon for the BAV. We always go, we can show here with the extra syringe. So it will be a 22 Z-med
Yep,
and
Z-med
with a 10 cc extra syringe. Hold the wire.
Yep,
Pacemaker,
we have it.
who has it?
Who's got the pacemaker? Wiki? Yeah.
Little difficulty in getting the balloon there.
Okay, good.
Okay, good.
There's a little
Yeah.
extra tension on the wire.
Yeah, yeah, pull back
They
the
will
wire.
pull the
little bit.
wire, yeah.
Yeah, good.
Good.
Okay, start pacing, 180.
Maybe a little too far. Yeah.
No, no, that's good, that's
Okay,
good. You
good.
have the valve. Good.
It bounced up.
With the balloon.
Or it
Okay.
went up at a pretty
Good
high
BAV.
pressure.
Yeah.
Stop pacing.
Good. That's
So
great.
this is also very important. You tell them to pace 180 and you make sure your blood pressure goes down, which has to be less than 50, and at that time you inflate with the balloon, so there's no movement of the balloon.
AI is unchanged. Aortic regurgitation is unchanged.
Good.
It's mild to moderate.
Okay, let's bring the valve, which is 29 millimeter. Okay, we go to overview.
Wire
Good.
pull back.
Just hold it. Yeah.
All right, you got the floral.
I have it.
So now
So
you
now
see
you
that
get your pigtail in position.
And the more important is that you see that the wires, this device has become so easy in terms of tracking. Once your wire is in position, it will track nicely. Yep, here, looks good.
I think we are
a little bit
way
in,
down.
A little bit low.
Yep.
Yeah.
You take one picture.
You want to move the wire a little bit, hold it. Let's
pull.
move a little bit inside, outside.
Good.
We take the tension out.
Yep, we did.
It's nice sitting. Okay, we are going
Jiggle.
to go on
Picture.
Cine.
Yep.
Oops, hang on a sec.
Inject. Okay.
Still a little bit low.
I
You
think
gotta
we're a
make
little
sure it
low.
doesn't dive.
So we are about
'Cause we're
starting
on the
at
low
6,
side
right?
here when that side's going to be low.
Start releasing.
Start
We're going to
releasing,
Start releasing.
okay.
Yeah. I'm just holding
17,
with
18,
both my
19,
hands.
20 turns. Going to start coming up. There we see the distal end engage.
I think we went down.
It's down. You better pull back.
Oh, yeah.
Yeah.
Hold on.
Good.
Hold on. Hold on.
Yep.
It's positioning has changed a lot.
Yeah.
Bad angle. Wait. Pigtail moved.
So it's very important that your pigtail is in the non-corner. Yeah.
Do you want to go? I'm going to go forward a little bit.
Yeah.
It's
This is good.
straightened.
Yep.
Then
No,
come back.
No. I'm going to go with the wire a little bit so it goes to the outer.
With the wire, you mean?
Yeah. Okay. Good.
Okay.
That's fine. That's fine.
That
Okay. We're
looks
going
better.
to take another cine.
I think we'll be
I
okay
think that's
now.
okay now. Ready?
Yeah.
Starting to let it flare. Hold
Okay.
tight.
Flare. Flare. It's going to jump. Ooh, 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 ooh. Good.
Okay. It's
No.
going to be all right.
No, it's
Should
too
we
much coming
pace?
out.
No. No.
No,
We're okay.
it's going to be all right.
You take a
Okay.
picture.
Yeah, take a careful picture once it is
Yeah, we're good.
flaring.
Just
and
right.
Okay.
Okay.
I
Yeah.
think has a,
Start pacing.
I think has about a 2 millimeter length on the right side, and once it stays
Keep going.
there,
You
that will
gotta
be
pace
really
more.
good.
You're not
Release.
capturing. You're not capturing.
Yep, we are doing it
Go.
now.
Go. Release.
Good. 120. Yeah, low pressure. Good.
So in many sites, pacing not absolutely essential. In this part, in our site, we always pace at about 100, 120 beats per minute, just to avoid any
Okay, I'm gonna stop
instability
there.
from extra beats, etc.
Stop pacing.
Stop pacing.
60
Ready
Or-
for injection.
This valve at this point is fully functional
Good.
and open, so we can take our
Okay,
time for the
release
final
it.
adjustment and all that.
It'll adjust itself now.
Yep.
Releasing the rest of the
Release.
way.
Release. Good.
Okay, we
Yeah.
got it.
Came out. Okay.
Already separated.
Mhm,
Yes.
It's separated. Got the nose cone through good. That's it.
Okay.
And now we stop at the descending aorta, so we can marry the nose cone with the delivery catheter, as you can see, and then
Coming out.
everything is removed unblocked, while maintaining the wire in the LV for
Partha looks okay?
further hemodynamic
Yes,
assessment.
so
There's some
what you see now
paravalvular
is in
leak.
the short axis, and there's a paravalvular regurgitation at 12 o'clock position, which is moderate. There will be, it's slightly underexpanded. The valve, there's a gap there. So perhaps a balloon
26
dilatation is going to be
millimeter,
needed
right?
at this point.
Yeah.
I'd go lower.
Didn't we say?
I was going to say 24. But
We decided
26
24.
direct.
Yeah, 26.
26 direct because we did a good valvoplasty. We'll
Okay.
see.
Ready for the
Okay, now tee up,
Yes.
please. Yeah.
inject.
The level looks pretty good. Where
Yeah,
we put
nicely
it in. I don't
positioned.
think it'd get any better than that.
Yeah. It just need to adjust a little bit, right?
Yeah. It does a dance and moves.
Keep it there. Yeah. So that we can have a 26. We don't need to go inside right now.
No, do we need?
Yes. What do you think? We need, right?
Yes.
Echo wise.
Based,
By,
Echo-wise, there's
based
a-
on the echo, looks like there is a paravalvular leak at 12
Yeah.
o'clock that
Yeah, and
may
see
be
that-
helped by
look at the-
dilation.
Look at the 12 o'clock position. There's a gap,
Yeah.
and from where
Right.
the
Based on the
paravalvular regurgitation
hemodynamics.
happens.
No, but
No.
it's not
Can we
attached.
see the hemodynamics on the monitor? Actually, that would be very
Show
interesting.
him the diastolic. Diastolic did not change.
But we didn't go into the ventricle yet, just
We have a
because
PA.
we want to do it only when.
PA.
How is the PA pressure
Up a
now?
little.
So based on the CT sizing, what balloon size would you use for the predilation? And
I mean,
how do we
ideally would
calculate
be 24,
25.
but with the
No, but point is there's no 25 the direct, so it's a 26. We want me to the direct to me. Anytime you have a stent expansion, the issue you usually this 20 the direct balloon really gives you that pressure, so it inflate to the same size what it is meant to
The
be.
direct or the true balloon?
True balloon.
True.
With a true balloon, yeah.
A true balloon.
Yep.
You go directly with true balloon.
Yeah.
That's what you mean.
Who
That's
has a pacer? Same 180, okay?
So you will go with
No,
26 true
I'm not-
balloon?
It's a 26, yeah.
Yeah.
It wasn't capturing so good. We might need to go 160 here.
Okay.
Yeah, we got to be a little careful with the capturing. We have to, when the post dilation, we have to pace now at 180, 160 to 180, and we have to have full capture to avoid movement of the valve medially.
Okay, start with 180.
We'll probably go a little bit better, more in.
Yeah, you got it.
To aortic.
Okay. I'm
Now we
going
go
up.
down. Okay.
Good.
Go fast. You should not wait. Continue pacing, continue pacing. Continue pacing. Continue pacing. Okay, stop pacing.
Okay, we have a good stability, a full expansion of the balloon. Very important to have the true balloon because you saw that the edge of the balloon was really
I
where the
think
valve plane was.
Partho
And,
should look okay now.
Yeah, it's much
Let's
better.
look at the TE.
Better.
You can see that the paravalvular leakage is much better. I think this is an acceptable result.
Yeah, the
This
gap
is a good result.
Yeah, that's essentially a trivial, mild AI, trivial to mild
Yeah, but
paravalvular leak.
that's a
You
transvalvular
can show both
because there's a
how the
wire
stent
across.
expanded. I took
yeah.
a picture before.
It's overall mild AI with trivial paravalvular leak. Let's
Yeah.
look at the hemodynamics with placement of the pigtail in the LV.
Yep.
And I
Okay.
think we will have a nice separation between diastolic and LV.
Now see this now, like that skirt, the constriction, the waist constriction, this is our true balloon. And but true balloon, you don't need to attach any extra syringe because it goes to the final diameter and it won't go further. Now see that constriction clearly has disappeared, and now we are going to do two things. One is the hemodynamic measurement, and the second is the aortogram.
Something we did not discuss, Dr. Sharma, is what kind of a stiff wire are we using for this procedure and valve procedures in general?
Yes.
This
Uh,
has to be the
There
extra.
is the extra
Ampli-
stiff and the
extra
super
stiff.
stiff,
This is super.
and there is some, I would say, choice between the two.
Yes.
We tend to use the super stiff with a
Not with
CoreValve
this
and
one.
the
You have
extra
to take it
stiff
out.
with a
Yeah.
by a sapien valve. In this case, you think
Okay.
there's really a difference between the two wires?
Well, I mean, the super stiff definitely has a little more chance of perforation, but that is what we require for the core valve because need the support. Compared to with the Edward or Sapien, we go with the extra stiff only.
Okay, ready for the aortogram?
Yep.
Okay, so we saw a very nice separation of the
Good.
pressures, and we have no
Not even
AI,
a single
Not RBC.
RBC.
no AI,
No AI.
and a very good feeling
Good
of the
position.
coronaries through
Probably
the
about
sinuses.
7 or 8.
It is a very nice picture of
Yeah.
the valve and the feeling of the coronaries from the sinus that are circumferential
Glad we pulled it
to the
out.
waist of the valve. The
Definitely.
valve is placed at about a 6 millimeter depth,
I know.
which is optimal, and hopefully the patient will have no
When it
heart
started
block
to flare, it
with this
started
type
to
of
turn.
placement. Can we see the hemodynamics and the
But
heart
we
block?
started a little too deep.
So,
That
I
still
mean,
wasn't
patient
good
has
enough.
some pacemaker dependence, but you should remember patient has AFib, and now we are rate of about 50. There is still some captures.
So
actually.
it's more of bradycardic really,
Yeah.
but I think this will recover with a little, it's already recovering and
Yes.
going a little bit fast.
Yeah. So this is not uncommon, and the whole issue remains is this the issue of post dilatation. People have concern that whether this post dilatation will degenerate the valve or associate with various issues, and that will be my part of while we are done from the procedure point of view. Now Jason can start doing his closure of the vascular access,
Yay.
which has been done
Yay,
with the
pressure's
pre-close
better.
and so. And if we can go with the slide so that we have 5 more minutes, we quickly go with our theoretical point on this issue. Next slide.
Ventricle looks
And
like
that
it's
is the
squeezing better.
where are the this is our core valve. Next,
Yeah.
that next is basically the current role of BAV in management of TAVR pre or post procedure. Next. Now, we know that we do a balloon valvuloplasty for very extreme risk cases and so forth. And this very nice paper just came out 2 weeks ago in JACC intervention from the partner trial. The patients who were in the inoperable arm, the group and then they had various groups of balloon valvuloplasty. One group who had a valvuloplasty before patient were randomized, and then within the randomization group, some patients had a BAV next within 30 days. So you can, and others, they call it a no BAV, that they did not have any BAV. So basically, what it comes out to be the next, that if you have, of course, next, the previous BAV, those patients are high risk, means before randomization that you needed to do a BAV. But key is that if you did a BAV, you can see the 30-day next and 6 months outcome, particularly 30 days, were better if you do a BAV within 30 days. And of course, next, the benefit was lost at 1 year. If you did a BAV before randomization, that those were probably very high risk patients, we know that they will have a bad outcome. Other issue comes that by doing a BAV, are you increasing the stroke or so? As you can see in the data here, there is no difference in stroke. So what is the message? Next, and the message basically is that in cases with severe aortic stenosis, particularly when you want to do the TAVR, and if there is a, by condition, doing a balloon valvuloplasty, you may optimize their condition in first 30 days and then go for the TAVR placement. Next, and this is also showed the functional improvement. Next, all the quality of life parameters, that by doing a balloon valvuloplasty you make them feel better. Next, and that actually goes down now, as you know, the latest guideline, that percutaneous aortic balloon dilatation may be considered as a bridge to surgical or transcatheter AVR in severely symptomatic patients with severe AS. Remember, the only inoperable or patient with a low gradient, though no longer that's the criteria. For the TAVR, what we learn many times, you optimize their condition by doing a balloon valvuloplasty and do the TAVR within 30 days. So I think that now, do we need to do every case? Like this particular case, who was walking, was in class 3 heart failure, I think that was okay. You do not need to do. Otherwise, this patient who has a gradient, let's say of 65-70, patient is in heart failure, admitted. So don't take them to the TAVR directly. But by doing a BAV, you'll stabilize the condition, and then doing a TAVR, in my opinion, will have a lower event rate. Next. The second is, what about post-dilatation? And this is what is done. Now, these are the two reports separately. One for the CoreValve, which is the self-expanding. Second is the data for the balloon expandable. Next. Now, this is 1100 patients. 20% require the post-dilatation, so that you have put the valve like us, then there is a prosthetic regurgitation, and you did a balloon dilatation in about 20% of cases. Now, what is the outcome? Next. And basically showed that you do a post-dilatation actually is not good. Means that you do a pre-dilatation probably better. Post-dilatation has a statistically higher mortality at 1 year in the CoreValve trial, and in the stroke incidence was no difference. You can see here the red, which is the post-dilatation, initially was a little higher at 1-2 months and later on caught up. So key is, what we learned in the post-dilatation in the CoreValve was associated with higher mortality. But next, but at least reassuring is that once you go to, next slide, that once you go to basically the multivariate predictor, it's not the post-dilatation which predict subsequent mortality. It is your paravalvular leak, CRF, and the usual risk factors of high Euro scores and so. So basically, the key is that it is the post-dilatation is required to decrease the regurgitation like this case, and I don't expect, and the data also for the CoreValve, there was no difference in stroke rate. So therefore, it's in the CoreValve, maybe higher mortality as a univariate predictor, but not as a multivariate, and no difference in stroke rate. Next. Now, if you go to the balloon expandable, which is our Edward Sapien, next, the data are slightly different. That is, there was no difference in death, but definitely you have a higher stroke rate as shown on the right side. So I think this field is still a little confusing or variable in my opinion in the data point of view, but it does make sense that if you can make your lesion prepare, means just like we do it for coronaries, that if you prepare your the valve for deployment of the TAVR procedure, and you don't have to post-dilate, that is okay. And we also learned, particularly with the CoreValve, leaving 1.5 plus aortic regurgitation or prosthetic regurgitation, that it does not translate into a higher event rate or subsequent mortality. Therefore, it's okay to leave a little bit of regurgitation rather than go with the balloon dilatation. Next. So therefore, if I sum it up, The BAV pre-TAVR has shown to be life-saving in extreme risk patients in first 1 to 3 months and should follow with TAVR appropriately. Very important message. You do it and you do it within 1 month. Next, the balloon post-dilatation post-TAVR requires in about 1/4 of cases and has shown to be associated with adverse outcome of mortality and maybe stroke. So this is just again, both data are variable. Next, and I'll just go through our 3 questions which we always try to put so that those who see the case and we want pertaining to our presentation, I always put 3 questions. Following are the true statement regarding BAV in extreme risk AS patients. 1-year mortality is lower with BAV. CVA incidence is higher with BAV. Mortality is lower at 3 months but not at 1 year with BAV. And mortality and CVA both are lower with BAV.
With BAV,
Next, yeah, with the CVA will change it. Yeah. Next. Second, the following are the true statement regarding balloon post-dilatation post-TAVR. That is, incidence is 15 to 20%, or 40 to 50%, 50 to 75%, or more than 60%. Next. And the last is the balloon post-dilatation post-TAVR may be associated, maybe, because of the data I showed, with following, except valve degeneration, higher mortality, higher CVA, and lower prosthetic regurgitation.
Actually, Partho, you wanted to say something?
Yeah, I wanted to just
Great. All these are very interesting questions, and obviously we'll have the answers at the website.
Can you show the echo again?
Yeah, so I just wanted to report a dramatic improvement in ejection fraction from 20% to 50%.
Wow.
So a remarkable improvement on the
indeed, indeed. There's an immediate response.
Yeah, and this is what I have been saying, and you know, we are the preacher of balloon valvuloplasty. We published paper in 2005, repeat valvuloplasty. This is before the TAVR days. That repeat valvuloplasty does prolong survival. The key is that people are very much concerned about the BAV having the risk of stroke or severe AI. I can tell you all those combined. We do about 200 balloon aortic valvuloplasties. Risk of stroke or severe AI is less than 1%. Less than 1%. While many of these cases have a dramatic improvement, more importantly, stabilization of their condition and improvement in the ejection fraction. And you want to point
as a very good demonstration, Partho. Thank you. And we saw the EKG has survived, has recovered as well.
Yes.
Yes.
And all these are going to can be found in the website, the structuralheartlivecases.org. And in the archives, you will find this case and the continuation of the case with a Q&A and any responses to any written questions you can post in the days and weeks to come. As you can also view in that site any previous cases of structural heart we have performed in this webcast series. Let's go back to the cath lab for the final goodbye from the cath lab and then back to me. Any comments, Dr. Stelzer, Dr. Kovacic?
Yep.
You're going to perform the closure now?
Yeah. If you want to just show quickly the cines, we can just in 2 seconds show the closure. Just the final shot even, just the last thing that's playing. So this is the final DSA shot. We still have the wire there, but the per closers are deployed, the sheath is out. Almost no sign of where we actually entered the vessel.
Show the fluoro there.
Very
so one more, next fluoro, there we are. First we retrieve the sheath in the external iliac. We check there's no perforation up top. And after the per closes, we checked, and as you can see very nicely, there is no problems at all with the flow, no extravasation. We have perfect hemostasis. Now is the time to partially reverse the heparin and pull the wire and end the procedure.
Exactly. So the protamine's been given. We'll just pull the wire and we're done.
And here will be same. Dr. Levin will try to extubate the patient before going to the coronary care unit. So that are clearly what we learned, and maybe I'll talk about next time with a fast TAVR protocol. So there is a whole issue is happening because everybody knows that the TAVR cost is so high, 30,000 versus the surgical valve is 5,000, that how can we accelerate safely decrease the cost of the TAVR procedure? And part of that is don't get a bypass pump primed on, because that again is the cost. Second, try to do a less invasive monitoring and fast track protocol they call, basically discharging the patient in 36 hours rather than usual 4 days. So we are actually having some success with that, and in the past we used to leave a pacemaker for 48 hours like religiously, but now in many cases with the consultation of the EP and use of pacemaker, we have taken out pacemaker even that evening after 12 hours. The earliest patient of the TAVR we have discharged at 36 hours. So patient had a procedure done at 12 o'clock and went home next day at about 7 p.m. So therefore, few patients safely can be discharged next day, and particularly if there is no need for pacemaker, because if you have pacemaker requirement, you need to wait at least 48 hours. So unless the EP team, our electrophysiologist says that this patient is guaranteed going to need a pacemaker, so rare cases we are done after the TAVR pacemaker implantation right on the table. The second issue which you pointed, which Partho pointed out about the clot in the left atrial appendage, in this particular case it's already lined, organized, and which is not uncommon for many of these AFib patients. So therefore now, with the Watchman device clinically available, so this issue will come up in many of these patients, that those who cannot take a oral anticoagulation for a long time, that do a Watchman pre or post. We actually had 2 patients who are in the wings who are going to get a Watchman, one before and one after the TAVR, and idea is that they don't get a continued long-term anticoagulation.
That's great, and I would think that dropping a little bit the price of the TAVR valve would also help the economics of this, but that's definitely at another level of discussion.
Yes.
I think it's exactly 10 o'clock. We had about 5-10 minutes delay in starting, but I'm pleased to announce that the webcast is close and completing on time. I would like again to invite everyone who is watching this to also go to the cccsymposium.org website and register for the clinical symposium we have with live cases, coronary, valvular and vascular live cases symposium at the AXA Equitable Center near the Times Square, June 17 to 19 here in New York City, and also enjoy the personal interaction with all the Mount Sinai faculty, not only performing the procedures but also being on site and interacting with all the attendees. And we will see you for another webcast in approximately 2 months. That will be posted in our website, structuralheartlivecases.org. Thank you.